Good evening from Rocky Mountain PBS. I'm Cynthia Hessin. This is Colorado's State of Mind. Colorado is now 10 days away from the early rollout of the new state healthcare exchange, and the people about to debut that marketplace are working round the clock to be ready. Health Policy Solutions reported last week on how there were still some data sharing problems between Medicaid and the exchange, so they're working on that. The federal government, meanwhile, is working hard to make sure everyone understands this health insurance exchange is primarily for people who don't have insurance now, age 64 and younger. Americans over 65, of course, have access to Medicare, and nothing about that is changing. Tonight, we want to focus on the access to health care that is about to be gained for those Americans who haven't had it, and about the programs in other areas of the country which are already making progress on closing the access gap. The Colorado Trust brought a group of experts to town this month, all officers of health foundations, and we're glad that they had a little time to spend with us as well. Nichole Maher is the president of the Northwest Foundation, which is focused on prenatal through youth health strategies in Oregon and Southwest Washington State. Elizabeth Krause is in town from the Connecticut Health Foundation, where she is VP of Policy and Communications. Dr. Calonge is their host, chief of the Colorado Trust, where the goal is achieving access to health for all Coloradans. And Dr. Yanique Redwood heads the Consumer Health Foundation, which concentrates on achieving health justice in Washington, D.C. So each of you has been working on health equity for a long time, and your Denver audience is about to learn some of your successes, maybe your lessons learned. So, Nichole, tell me what is happening in Portland. What are you seeing there?
Well, Portland and Oregon is much like the rest of the United States, where we have exponentially increasing level of diversity. The demographic is absolutely changing. And while these populations are growing, the disparities that we historically have faced over the last 100 years have actually not been decreasing, they've been increasing. And so what that means for Oregon and Southwest Washington as communities is that as the demographic of our community shifts, our entire state and community pays a consequence when everyone doesn't do well together. And we as a foundation have actually been finding that as you look to communities and ask them where they find the greatest success and ask them to implement their own solutions and bring leaders together to find collaborative system reform and policy changes, you actually get the best outcomes. And so as a foundation, we've been making investments and partnering with the community to increase the number and the types of voices at the table around health policy. We've been making investments in sort of system reform as well, but with very much a community-led effort. And we also have been working in the past year to really look at where the foundation is going and recognizing that as a country, our young people are actually experiencing a lower life expectancy than their parents, and we want to change that. And we think that the way to do that is by making investments early on and actually focusing on the communities where there is the greatest opportunity to make an impact, and where we believe there's the greatest opportunity to really change outcomes is largely in communities who have been underserved.
Yanique, in Washington, D.C., what is health justice? What are you fighting for there?
So the Consumer Health Foundation is actually located in D.C., but we focus on funding in the district as well as Northern Virginia and some parts of Maryland. So we're really a regional foundation. And when we talk about justice and health justice in particular, we're really, we focused on health care, which is really important, but over the last, I say, 4 or 5 years, we've really decided to move beyond health care, to increase funding for all that it takes to be healthy, including affordable housing, food, access to good food, educational opportunities for young people. So it's health care and everything else that it takes to be healthy. And that's what we mean by health justice.
Elizabeth, you have been doing this for quite a while as well. What would you say is the biggest success, or if you prefer, what do you think is the biggest failure that you might talk to Colorado healthcare providers about?
Well, in Connecticut, we are a tiny New England state that often doesn't get a lot of consideration by people in other states. So I'm so glad that you've had me here to talk about what the Connecticut Health Foundation is doing. Connecticut is the wealthiest state in the nation, but the relative wealth brings the inequities experienced in some of our nation's poorest cities and Connecticut into stark contrast. So Connecticut is home to Hartford, Bridgeport, New Haven. These are all cities that are majority people of color, and they have really big healthcare challenges.
Underserved populations.
Underserved populations. Connecticut, like Colorado, is a leader state in health reform. We are also implementing a state-facilitated exchange, so we're actually very focused on using the Affordable Care Act to level the playing field and to create more health equity. There are numerous opportunities embedded in the ACA, including but beyond expanding health insurance coverage. So this is a very promising, concrete strategy for closing some of the gaps. I think what's been a challenge with the health equity issue is that it's so huge and the problems are so entrenched in society, and we make incremental progress. But what we're really excited about in Connecticut and for the nation is the opportunity that the healthcare law provides to us.
Are the providers in Connecticut ready? Do they expect sort of an onslaught of people, or how is that going to roll out, do you think?
Well, I think ready is a subjective term, or well, the answer will depend on who you ask. But ready or not, it's coming, and it's the law, and we are going to, as a foundation, try to make it as successful as possible. But I think the message is that it's not going to happen October 1 when open enrollment begins. It's not going to, everything isn't going to fall into place January 1st when coverage goes into effect. It's going to take a couple of years to see the full impact, and like with a lot of major national social policy, healthcare policy, we will see the benefits over time.
Now, that is something that has occurred to me since the last time we talked when you were here. It is the law, but there's certainly still a very active movement to try and either overturn Obamacare, or even its supporters say there are some things that need to be straightened out. What do you see on your radar screen about that?
I think we are starting to more fully understand some of the flaws in the law that would easily be fixed if we were all working on it together. If our leaders in Washington saw the opportunities that I think many of us do to expand coverage to people who don't have it now, to address health care inequities as well as inequities across the spectrum of the determinants of health. They're embedded in the law, and trying to tease out those opportunities and fix the flaws is where we really should be working, because it's the law. And so that's, when I talk to elected officials, it's always about it's time to figure out how to take the law and meet the opportunities that folks have taught about. The issues about employer mandates and how that's going to roll out. Are employers going to take different approaches to how they hire and for how long they hire to avoid the requirements of the law? I think those are things that will shake out over time. I've been impressed how employers really want to find a way to provide this benefit to their employees. They recognize that healthy employees increase their productivity, and they want to support and maintain their employees forward into time. So there'll be a little bit of awkwardness, I think, at the beginning. It's the first year of a really big experiment, and I think folks need to recognize that. We'll learn a lot, we'll make changes, and if we can embrace this concept that increasing coverage will answer a lot of the gaps that we've talking about, grab the opportunities and fix the problems, I think the ACA could be a great thing for the country.
So, Nichole, what you said earlier about life expectancy, that really is startling. We're hearing more about it now, that this generation really doesn't necessarily expect to live longer than their parents. Talk more about that.
Yeah, it's really unfortunate. I think it's the first time we've seen evidence in an industrialized world country that the children born really now and in the last 5 years have a lower life expectancy than their parents, and it largely has to do with issues such as obesity, diabetes, and other really preventable causes. And so in a time where we've had really phenomenal advancements in our medical system and so many wonderful things have happened, a lot of people will not necessarily see those benefits because of other circumstances. And we really have an opportunity to talk about that. And the communities who really are seeing the worst outcomes tend to be our African American, immigrant and refugee communities, Latino communities, Native American communities, and Asian Pacific Islanders. And so we have certain segments of the population who are also our absolutely fastest growing populations who are carrying a deeper burden. And because of the increasing diversity of this country, everyone experiences those negative outcomes together.
In your area, a lot of Native Americans are involved in this underserved population. Isn't that right? Are there cultural differences that prevent access in those communities?
Well, I can speak for, in Oregon at least, interestingly enough, the very populations who have some of the deepest disparities actually also have the lowest levels of insurance and access to care. So that's a significant barrier in itself. There are certainly challenges about cultural responsiveness within the system, but largely it also has to do with simply not having insurance, not having access to prevention. And then the other big piece of work that the foundation has done is really looking at all of the systems that we have across our communities that are really engaged in prevention. And we're actually finding that a lot of the prevention messages don't reach a lot of those populations, and a lot of public health messaging historically has been sort of a one-size-fits-all. If we get the message out, everyone will hear it, and that actually is really been shown not to work. There really needs to be tailored, specific messages and outreach efforts that really take the best of each community and the strengths that they have and match that with prevention messages that are really community-led.
Are you going to follow up on what she said, Ned?
It was on the comment about the lower life expectancy. I think we point to things like chronic illness and obesity, and those are really important. But I think the underlying demographics in themselves, remember, it's the average life expectancy. And so if we have disparities in place that primarily impact communities of color or traditionally underserved populations, and we increase the number of people and with changing demographics and increasing diversity, that, as you said, the simple math says if we take a health inequity and we spread it over a larger population, overall life expectancy will come down. And I always want to make sure that we never lose sight of that, because that's one of the things that work in the health equity field will help increase that life expectancy back up. So there's a big gap now between people at higher income levels and people at the lower income levels that we can demonstrate in terms of life expectancy. And you've demonstrated in D.C. just along metro stops, right?
That's what I was about to say. I mean, I really appreciate this conversation about life expectancy in terms of generation and then in terms of different groups. But what we're seeing is difference just in place, right? So on the eastern side of the D.C. region, people living there can expect to live a full 9 years less than people in the northwest part of our region. So it's not just about race and class and generation, but also place, that we're seeing these huge disparities across the region.
Does that have to do with transportation and housing? Or?
Right, so the access to healthcare issues that we've been talking about are really important, and also the high burden of chronic diseases within populations that have typically not had a chance to even be able to go to the doctor. So that's clearly important, but also just everything else. I mean, poverty it's a really serious issue, and not just the material things that not having enough doesn't allow you to buy and to be able to secure for yourself and your family, but also the stress, the chronic stress of being poor and having to figure out how you're going to get by, what that does for your body is important. So So it's not just the material things, it's also what poverty does for you mentally.
There was a study just
exactly.
recently released about that, wasn't there? Pointing exactly to that stress.
That people have less bandwidth to even really manage their lives because they're so consumed with trying to figure out how to make ends meet.
Elizabeth, you pointed out earlier the contrast between Connecticut being a wealthy state and yet having these underserved populations in the big cities. Does that make it harder to get people rallied behind the cause of what you're doing?
Sometimes we can use the advantages in the state and extend them to the underserved populations, and other times it does make it hard because the issue is often concentrated in areas that people who have resources don't see, so it becomes invisible. But it's part of the mission of the Connecticut Health Foundation to help shed light on the shared fate of all Connecticut residents, and that's a theme that we just touched upon. And what I find so important about the prediction that the generation born today could be the first to have lower life expectancy than their parents is that that's a wake-up call to us as a American public. I'm a new mom. That's not what I want for my children, and I would question whether that's what anybody wants for their children or what we want for the future of our country. And so I don't want to be alarmist, and sometimes those of us who toil in statistics can go overboard in ticking them off, but that's a pretty staggering finding. And I think with some of these issues, I think to find the so-called common, uncommon ground, so chronic disease, obesity, these are healthcare issues that are crossing socioeconomic lines. It's a big issue for the country, but it's even more of a burden for certain underserved populations and populations of color. But if it's something that we're all facing together, what are the strategies that help all of us? And then it's a term called targeted universalism, where it's a universal issue, but we can go in and look at the tailored interventions and messages for the communities that need a different message. Exactly.
So do you see in Obamacare help in doing that targeted intervention?
Well, I can talk a little bit about what's happening in Oregon. Our governor has done a pretty phenomenal job leading healthcare transformation and created in 15 regions, it may be 16 soon, coordinated care organizations, and really asked communities to unify and come together. Also having what's called a community advisory committee to help govern those efforts so that those communities can actually come up with solutions that meet the unique geographic needs, the unique cultural needs of those regions. And then I think where we get excited as a foundation partner is really this hope and this idea that with those tailored regional approaches, there'll also be an opportunity to have many more investments around prevention. It's very easy right now to sort of think about the short-term gains that you can make in cost savings, but we all know that if we work really hard to have healthier births, healthier early life outcomes, we're going to see an overall healthier population. The cost savings for that take longer, so it's a harder case to make, but I think that there's a real opportunity for those of us in philanthropic roles or other policy roles to continue to push as hard as we possibly can for investments earlier in life, because they do have such important gains later on.
Before I run out of time, I want to ask each of you individually why you do what you do. I always find that kind of interesting. Get interesting answers on that because public health is such an interesting mission. So I think I'm going to start with Dr. Ned Calonge. You headed the Colorado Department of Health for a good time, and why did you decide to go that direction?
You know, it's interesting. I'm a family doctor. And in patient interactions, there was always this feeling that I was dealing with the outcomes of things that should have been addressed far ahead of time. So I became very interested in prevention and preventive medicine, became a zealot in that area, and so in my early clinical work, that's what I did, was champion prevention programs. The leap to public health was really saying, you know, could I do what I did at Kaiser, where I had resources and a system that wanted to push the prevention agenda, and do that on a statewide basis, really bring that level of concentration on moving back to prevent disease rather than just take care of it, and do that for the state of Colorado. So that might have been a little naive at the time, but that was really the vision that I saw trying to bring forward, and public health was the way to do that.
And in this time since you started, do you feel prevention has pulled ahead of where it was?
Well, it's a great thing. Well, at least we're paying more attention to it. It's still a very small part of the healthcare dollar. And yet it's starting to emerge, and we understand the importance of not just preventive services, but in trying to build a culture of health throughout society, so that we really do pay attention to healthy eating, active living, our weight, our health, our social interactions, our sense of community, our community resilience. These are things that really determine how long and how well we live. So that's a norm. For me, it just makes sense to move from public health into the philanthropic sector, where we can take risks so we can do things that you really can't do in government.
Elizabeth, I'll turn to you next. How do you happen to be heading the Connecticut Health Foundation?
Well, I actually have to give some of the credit to some early experiences here in Colorado, including working with Ned Calonge when he was at the health department. I spent 2 years here very early in my career working on the issue of health disparities and health equity, and it became a life's work for me. I think a light bulb went off at one point when I became intrigued with what philanthropic organizations, what foundations can do. The way we work is creative. It's different. We can leverage, we can convene. So we certainly fund grants, but we do so much more than that. Some people might question how hard it is to write a check, but I think if you were to ask any of the foundations here, we do so much more than that, and it's really rewarding work.
And I misspoke. You're not in charge of the foundation. You're the VP of policy.
I was willing to take that.
Well, just in case whoever is in charge here sees the program. How about you, Nichole? You came out of this same area where you're working. Grew up there?
I'm actually originally from Southeast Alaska, and then also grew up in rural Oregon, so I'm kind of an Alaska Oregonian. Prior to coming to the foundation, I spent 11 years as the executive director of the Native American Youth and Family Center. And my background, I'm Native American as well, and our community actually had a chance to go through a real transformation where we were the poorest community, we were, had the highest dropout rate, a whole host of disparities, and our leaders came together and really decided to create a new future for ourselves and recognize that no one was going to come and save us, and we needed to think about what we wanted for ourselves. We had lots of philanthropic support along the way, but once we decided that health and really investing in housing, education, community collaboration, and self-determination were really what would be most important. We saw tremendous outcomes, and I loved that experience. And when I had the opportunity to think about how to bring that learning that the community really holds its own solutions to the rest of our region, I was very excited to do that, because the leadership of our foundation, with our past president, our board, and our staff has always sort of had that vein. So it seemed like a perfect place for me, and I feel really fortunate to be there.
That's great. So that leaves you, Yanique. You studied at the University of Michigan. How did that set you into this direction?
So it's really interesting that you started there, because that's where I was going to start. So graduate school was the moment for me where I learned about the many disparities that we are all talking about today. And the public health field does a really nice job of documenting disparities between groups, between racial and ethnic groups, for example. And when I left graduate school, I wondered, what then do we do? And for me, being at a foundation, like Ned says, allows for that experimentation, for seeding innovative projects that then can be, that the private and public sector can then take on and run with. And so philanthropy is the place where I feel like I can act on some of these inequities that are so present in our society.
I wonder if I could ask you all to talk about the journey that your foundations have taken from what was probably, or at least for us, a more generic focus on health to this more focus on health equity.
Anyone can start there.
Yeah, I mean, so we began our journey about 20 years ago as a foundation and focused a lot on health care and health promotion. About 4 years ago, we had a series of community conversations where people were naming much more than health care in terms of what it takes to be healthy, including daily experiences of racism and discrimination. And so that was the turning point for us to really try to figure out how to go beyond healthcare to include everything else that it takes to be healthy.
Nichole?
Yeah, we started about 15 years ago, and initially we were very responsive. We funded, at one point an ambulance in one community, electronic medical records, lots of clinics, and over time we just really evolved to come to a place where we believe that policy and leadership, as well as bringing communities together to collaborate, is a great way to go. We were also heavily influenced. We have a deep partnership with Kaiser Permanente and make some investments together. And it was actually their leadership that helped us to understand social determinants of health and the absolutely amazing returns you can have. So they've actually influenced us in really, really positive ways, especially to where we are today in our investments in young people.
All right, and the last word from Elizabeth. How has your journey been?
The Connecticut Health Foundation has prioritized reducing racial and ethnic health disparities since 2000, but it was just this year that we reframed our funding priority. So we are now using the terminology of health equity, and we are making that our central focus.
Thank you. And that is Colorado State of Mind for this week. You may see the program again at video.rmpbs.org. Thank you now to Dr. Ned Calonge and Nichole Maher, and to Dr. Yanique Redwood and Elizabeth Krause for their insights tonight on public health. Next week, we will learn more about the 51st state, North Colorado. That's a proposed 51st state, that is. A secession movement is going to be on the ballot in 11 Colorado counties in November. We'll talk to some of the people behind that idea and find out why. We'll also have an iNews analysis of the numbers, what the economy, education, energy, and environment would look like in these two new states. Please join us for that next week, and thanks for tuning in this weekend. I'm Cynthia Hessin. Good night.
In the next couple of months or so, I think we'll go live, we'll go public, but I think everyone in the nonprofit world knows, because we've been talking about it for a year, and so it's becoming official, and we're really pretty excited.